Hello all and welcome to our presentation. This study is a single-site, randomized, double-blind, placebo-controlled clinical research study of bacteriophage therapy for Pseudomonas aeruginosa infections in adults with non-cystic fibrosis bronchiectasis. I am Claire Landgren and my partners are Caitlin Koenig and Brian Leverts. The goal for the study is to evaluate the safety and efficacy of a novel bacteriophage therapy, or CF1, in patients with non-CF bronchiectasis. This randomized, double-blind, placebo-controlled trial will enroll 154 patients with non-CF bronchiectasis as confirmed from a historical CT scan and Pseudomonas aeruginosa infection as confirmed from a sputum culture result. Patients will be randomized to receive either a one-time treatment of CF1 or placebo, in addition to their standard of care treatment. The primary endpoint of this study will be reduction in Pseudomonas aeruginosa as measured by the colony-forming units on a sputum culture at baseline and at week 6. The study will evaluate the potential of bacteriophage treatment as an option for patients with bronchiectasis. The results of this research may provide important information on the efficacy and safety of CF1 and the potential to utilize other bacteriophages as an alternative or supplement to antibiotics. This research may help to decrease the negative effects of bacterial resistance to antibiotics and improve patient outcomes. Background and importance of the study. The incidence of non-CF bronchiectasis is increasing. In the United States, it can be estimated that over 100,000 people are currently being treated for non-CF bronchiectasis. The prevalence is only 4.2 per 100,000 in young adults aged 18 through 32. But in older adults aged 75 years or older, the prevalence increases to 272 per 100,000. Non-CF bronchiectasis is defined as a permanent and abnormal widening of the bronchi. The cilia become damaged and the airway loses its ability to clear out mucus. The buildup of mucus creates a decreased airway radius, classifying bronchiectasis as an obstructive airway disease as seen in the figure. This mucus buildup also creates an encouraging environment for bacterial growth and often results in bacterial infections. Bronchiectasis is usually characterized by sputum production, cough, exercise limitation, and recurrent infections. These recurrent infections are a major cause of morbidity and mortality in patients with non-CF bronchiectasis. Pseudomonas aeruginosa is one of the most frequently identified bacteria in this population. These infections can lead to a progressive degeneration of lung function, frequent hospitalizations, and subsequently is a leading cause of morbidity. Treating Pseudomonas aeruginosa infections is difficult due to its capability to develop antibiotic resistance, even more so in these recurrent infections. Antibiotics is the standard of care for this indication, and these limitations indicate that there is an increased need for novel therapies. Bacteriophage therapy may be a potential treatment for these infections. Bacteriophages are naturally occurring viruses that have been targeting, infecting, and eliminating bacteria for billions of years. They attach to a specific host cell, enter their DNA, replicate, transcript, and translate their DNA, assemble new phages, and kill the host cell through cell lysis by bursting from the cell, creating several new bacteriophages that can now go and infect nearby host cells. Phages are highly specific and only affect targeted bacteria. They are able to leave bacteria, other bacteria, microorganisms, and human cells completely ineffective. This may lower the risk of resistance and pose minimal damage to healthy microbiota. Bacteriophage therapy WarPAM1 contains 4 bacteria that infect Pseudomonas aeruginosa and has shown effective results in preclinical and a promising phase 1 study. There is a need to investigate safety, tolerability, and efficacy of the investigational treatment in adults with non-CF bronchiectasis. Project aims and hypotheses. Our first aim and primary endpoint is to demonstrate a reduction of Pseudomonas aeruginosa. We'll quantify this by measuring colony-forming units at baseline and at week 6 on sputum culture results after treatment with either the study drug when compared to placebo in our patient population. Our second aim will be to demonstrate CF1's ability to reduce the occurrence of clinically significant or meaningful events. This can mean bronchiectasis exacerbation, incidence of hospitalization, or serious adverse events over the duration of the trial. Aim 3 of the study will be to evaluate the impact of the study drug on lung function and quality of life. Lung function will be measured with spirometry, and quality of life will be measured by a quality of life survey. Aim 4 of the study will be to identify any potential adverse events associated with the study drug and assess their severity and frequency. Assessment of adverse events will be done at every study visit.
We designed a phase 2 clinical trial that will randomize participants who have bronchiectasis to either receive phage treatment or the placebo at visit 1. Only one dose of treatment will be given in this trial, and patients will be observed for 30 plus or minus 2 days. Change from baseline in log 10 Pseudomonas aeruginosa, total colony counts, and quantitative sputum culture will be analyzed. The null hypothesis is that there's no mean difference in log 10 Pseudomonas aeruginosa colony counts from quantitative sputum culture in patients with non-cystic fibrosis bronchiectasis treated by a single dose of the Bacteriophage product. Then from those treated with the placebo at the end of the study period compared to baseline. The alternative hypothesis is that there is a mean difference in log 10 Pseudomonas aeruginosa colony counts from quantitative sputum culture in the treatment group when compared to patients treated with placebo at the end of the study period compared to baseline. Using a two-sided, two-sample t-test to detect mean difference between two independent groups with an effect size of 0.5, false positive rate of 0.05, and 80% power, we calculated that 64 patients per group will be necessary to detect a 1 log unit reduction in log 10 Pseudomonas aeruginosa colony counts using G-Power software. To allow for a 20% dropout rate, we have increased the group size to 77 patients per arm for a total of 154 subjects.
To be included in the study, patients must be adults ages 19 years and older, have a confirmed case of non-cystic fibrosis bronchiectasis with a Pseudomonas aeruginosa infection 1 year prior to the start of the study, and at visit 1. A full list of inclusion and exclusion criteria can be found in the full study protocol. We will recruit patients through relationships known of the investigators, through the UNMC bronchiectasis registry, through an opt-in research database, and referrals from outside physicians. Participants will be asked to complete an online eligibility screen to assure appropriateness to the study. To avoid bias in the selection and comparison of the two groups, assignments to the treatment groups will be randomized by performing one-to-one randomization to either the treatment or placebo group. A biased coin method will be utilized to prevent major inequities in treatment numbers. A central randomization coordinator will provide treatment assignments, and the randomization sequences will be available but blinded throughout randomization envelopes and provided after the patient agrees to be a part of the study.
The primary outcome measure is a change from baseline in log 10 Pseudomonas aeruginosa total colony counts and quantitative sputum culture. Secondary endpoints include the number of hospitalizations, length of hospital stay, mortality, bronchiectasis symptom questionnaire, St. George respiratory quality of life survey, safety assessments based on adverse events and tolerability, and some clinical outcomes. Potential confounding variables include health of individual, age, sex, smoking history, disease severity, level of antibiotic use, and steroid use. Secondary outcome variables of interest and potential confounding variables were determined from a literature review.
Going over our approach to statistical analysis. Our plan is to evaluate the difference between groups using analysis of covariance that is adjusted for the following predictor values: health of individual, age, sex, smoking history, disease severity, level of antibiotic use, and level of steroid use. ANCOVA will be used for secondary endpoints as well as primary. Two-sided t-tests will be used to compare unadjusted mean differences from baseline and 6-week follow-up between groups. Chi-square will be used to test categorical data with the expected cell count is greater than 5, and Fisher's exact will be used when the expected cell counts are 5 or less. As far as safety analysis, the safety profile of the product will be assessed by treatment emergent adverse events, laboratory values, and vital signs. These will be summarized by treatment group and overall. Any event that developed or worsened after treatment will be classified as a treatment emergent adverse event. If it is unclear when the adverse event began, then it is assumed that they are treatment emergent adverse events. These events will be summarized by relatedness to treatment, severity, whether they resulted in death, and if they led to treatment discontinuation or interruption. They will be presented using frequency counts and percentages by MEDRA, SOC, and PT. Observed values and change from baseline values for treatment emergent vital signs and laboratory values will be summarized by visit. Study is as follows. The study investigators will oversee recruitment for the study, and the accrual period for the study will be from January 2024 to January 2026. As individuals are seen in the clinic at Nebraska Medicine, they will be informed of the study if they are thought to be candidates. If the patients agree to participate in the study, informed consent will be obtained. Once informed consent is signed, the visit is considered visit 1 for the study. At visit 1, subjects will be screened to see if they meet inclusion and exclusion criteria for the study. If all criteria are met, then the subject will be randomized to the phased treatment group or the placebo group. A sputum sample will be taken to test for baseline. The subjects will also receive diagnostic testing and participate in questionnaires prior to receiving treatment. After all baseline measures have been taken at visit 1, the subject will be administered either the phased treatment or the placebo. The investigational product will be administered only by the investigators of the study. Only those who meet inclusion criteria are qualified to receive the product will be administered it. The investigator will keep a detailed record of administration and inventory of the investigational product. Bacteriophages will be stored in the refrigerator and will remain cool upon receipt. Placebo and phased treatment will be stored in the same manner. As it is a double-blind trial, they will be randomized and labeled by subject number. The subject will be followed for an observational period of 30 days, plus or minus a couple, when they will document any adverse events that they experience. After the 30 days, the subject will return to the clinic for visit 2, where they will have a sputum culture done as well as the diagnostic tests. The subjects will complete the surveys on quality of life and symptoms as well. Sputum samples will be collected in the clinic and stored in the refrigerator until testing, which will be done within 24 hours of collection. The testing laboratory meets good laboratory practice requirements, and the handling of specimens complies with policies and procedures set by Nebraska Medicine. Data will be recorded on source documents and case report forms. Study investigators are responsible for ensuring that all data is completely and accurately recorded. Data entry in the ECRF will be performed by trained staff and will include the complete data on all enrolled and randomized subjects. Screen failure subjects will not have data entered on them. One of the major limitations of the study is that it is a single-site study. This could result in the trial not being generalizable to the whole population, a lack of resources, and issues gaining the required sample size within a reasonable timeframe. Also, the study site does not have the capacity to run all pulmonary tests, as some can only be performed by the pulmonary laboratory and not in the clinical setting. It may not be worth additional costs and funding to run a full scale of pulmonary tests to see all the effects of the lung function of the investigational product. Also, patients who enroll in the study are chronically sick. They are not able to be taken off of standard of care medications. The individuals may be on different doses and types of antibiotics. These concomitant medications may give artificially positive results in the trial. Some of the ethical considerations of our trial are that the study will follow Institutional Review Board regulations and investigators will gain approval prior to the start of the study. The study will follow good clinical practices and be compliant with ICH guidelines. The study will also be consistent with the Declaration of Helsinki. Local, state, and federal requirements for investigational products will be adhered to, and study investigators will ensure the protection of human subjects by obtaining informed consent prior to any study procedures. Only authorized representatives will be given access to the study subject's original data. A report on the results of the study can be published, but the report will not disclose the subject's identity. A data and safety monitoring board will be formed to consider study-specific data and will have relevant background knowledge about the study, disease, and therapy. This board will review the protocol and plan for if the study needs to be stopped or subjects withdrawn. They will ensure the protocol is followed and plan for factors that may cause deviations. These are our references slides. You can find our references here and on the next 2 slides. Conclusion of our presentation. I want to thank you all for your time, and we look forward to all of your questions on the discussion board. Thank you so much. Bye.